Let's start our green top guideline number 74, which is antenatal corticosteroids to reduce the neonatal morbidity and mortality. First thing I need to mention is that sorry doctors for my throat, as I am having the sore throat, and sorry for that. So let's start antenatal corticosteroids to reduce the neonatal morbidity and mortality. And this guideline, it will supplement the nice guideline number 25, which was preterm labor and birth, which was published on 2015 and updated on 2019. And it will also the archived RCOG guideline number 7, which was again the antenatal corticosteroids to reduce the neonatal morbidity and mortality, which was published on October 2010. So, what are the key recommendations? A course of the antenatal corticosteroids given within the 7 days prior to the preterm birth reduces the perinatal and neonatal death and respiratory distress syndrome. For women undergoing the planned cesarean section between the 37 and 38 plus 6 weeks, are informed discussion they should take place with the women about the potential risk and benefits of the course of the antenatal corticosteroids. Although antenatal corticosteroids they may reduce the admission to the neonatal unit for the respiratory morbidity, it is uncertain if there is any reduction in the respiratory distress syndrome, transient tachypnea of the newborn, or the neonatal unit admission overall. And antenatal corticosteroids they may result in the harm to the neonate, which includes the hypoglycemia and potential developmental delay. The corticosteroids they should be offered to women between 24 and 34 plus 6 weeks gestation in whom the imminent preterm birth is anticipated, and either due to the established preterm labor, preterm pre-labor rupture of the membrane, or the planned preterm birth. Women with the twins and triplets they should be offered targeted antenatal corticosteroids for early birth in the line with the recommendations for the singletons, and birth they should not be delayed for the antenatal corticosteroids if the indication for the birth is impacting the health of the women or her baby. Antenatal corticosteroids they should be offered to women with the PPROM and who are at risk of the preterm birth. And antenatal corticosteroids they use reduces neonatal death, and with the first dose is given within 48 hours of the prior to the birth. And benefits are also seen when the first dose is given within 24 hours of the birth, and antenatal corticosteroids they should still be given if the birth is expected within this time. So background and scope, if you have the time you can read these, but here we are just going through the guidelines, and so that one can prepare fastly for the exam. So what are the benefits of the antenatal corticosteroids? A course of the antenatal corticosteroids given within the 7 days prior to preterm birth they reduces the perinatal and neonatal death and respiratory distress syndrome. And here, as I have mentioned earlier, if you want to know what are the evidence quality 1 double plus and what is the grade of the recommendations, like ABCD, you have to go through the video which I uploaded early, or the first video of these sessions, so you can go through there. Okay, and rationale for the recommendation. So these are the corticosteroids recommended by the Cochrane systemic review of the randomized control trials and supported by the NICE 25. Here again, this is the evidence 1 double plus. And now, what are the benefits of the corticosteroids in the planned cesarean birth at NICE CG 132 recommends that the planned cesarean birth they should not be routinely carried out before 39 plus 0 weeks gestation, and for women undergoing the planned cesarean birth between 37 and 38 plus 6 weeks, an informed discussion they should take place with the women and her family members or the carriers as appropriate about the potential risk and benefits of the course of the antenatal corticosteroids. Although the antenatal corticosteroids they may reduce admission to the neonatal unit for the respiratory morbidity, it is uncertain if there is any reduction in the RDS, transient tachypnea of the newborn, TTN, or the neonatal admission. Overall, and antenatal corticosteroids they may result in the harm to the neonate, which includes the hypoglycemia and potential developmental delay. So overall, an antenatal corticosteroids they may result in the harm to the neonate, which includes the hypoglycemia and potential developmental delay. This is very important. Okay, now let's move. If you want to read the comparison, the evidence level 4 and 2 minus, you can do it. And here there's a paucity of the evidence on the balance of the benefits versus harm when the corticosteroids are administered in the late pregnancy. Antenatal corticosteroids, they may increase the risk of the neonatal hypoglycemia in term neonates, and exploratory data for the trials of the corticosteroids in the late preterm birth and observational data. And there is some evidence that they may be associated with a developmental delay based on limited and incomplete trial follow-up and observational studies. As the risk of the respiratory distress is at term is low, such as 5%, and it is usually mild and transient, and there is a low certainty of the benefits. Clinician, they should discuss these factors with the women when considering the administrations of the corticosteroids prior to the cesarean section and the birth. So at what gestation they should antenatal corticosteroids be discussed and offered? What are the recommendations? And corticosteroids administration has benefit when administered to women in whom the imminent preterm birth is anticipated, either due to the established preterm labor, pre-prom, or the planned preterm birth before 24 weeks gestation. The obstetric and neonatal term, they should discuss the administration of corticosteroids at these early gestations with the women in the context of her individual circumstances and preferences. Corticosteroids, they should be offered to women between the 24 and 34 plus 6 weeks gestation in whom imminent preterm birth is anticipated, either due to established preterm labor, pre-prom, or planned preterm birth. 22. So, what are the risks and benefits of the antenatal corticosteroids to inform, discuss with the women and her family members or the carer as appropriate? So at the weeks between 22 to 34 plus 6 weeks, when the women in discussion with the perinatal care term has made an informed decisions that active care of the baby is appropriate. So what are the benefits? The highly likely to reduce the perinatal mortality, which is uh, between the zero point 0.9 or 2.3 fever, 95% CI, and the neonatal death, and again the neonatal respiratory distress, and likely to reduce the intraventricular hemorrhage, developmental delay in the children, and reductions in the above conditions are more likely to be seen if the birth is 24 to 48 hours after the starting the treatment. A reduction in the respiratory morbidity but not mortality or the intraventricular hemorrhage likely to be seen if the birth is within 7 days of the starting the treatment. So, what are the harms? They're likely to affect the maternal glucose tolerance for up to 5 days after the administration, with the high risk in the diabetic women, and likely to reduce the birth weights if the birth may more than 7 days after the steroids, and no benefits are likely to be seen if the birth is more than 7 days after the starting the treatment, and it may increase the psychiatric and the behavioral diagnosis if the children born at term. So, what are the uncertainties? And there is a less evidence for the women with the multiple pregnancies and effects of the unnecessary antenatal corticosteroids if the birth more than 7 days after the steroids and not well described. And while no long-term harms have been proven, large-scale observational studies necessary for the pharmacovigilance are the lacking. And so, what are the benefits if it is has been given between the 35 to 36 plus 6 weeks? The benefits are likely to reduce the respiratory support, and what are the harms? They're likely to increase the neonatal hypoglycemia, and it may increase the psychiatric and behavioral diagnosis if the child born at the term. And uncertainties, while no long term harms have been proven, large scale observational studies necessary for the pharmacovigilance are lacking. Benefit seems unlikely if the birth is more than 7 days after the starting the treatment, but this has not been studied in the women at this gestation. So before planned cesarean section, birth at term 37 to 39 weeks, and it may decrease the admission to the neonatal unit with the respiratory morbidity, and it may reduce the educational attainment at the school age, increasing in the proportion of the children ranked by the teachers as being in the lower quartile of the academic ability from 9 to 18%, and reduction in the proportion of the children obtaining English proficiency from the 13 to 7%. And uncertainties, there is uncertainty as to whether there is any reduction in the RDS, GTN, or the neonatal unit administration admission overall, and the risk of the bias in a single certain study means there is a low certainty about around the estimates, and short-term complications such as the hypoglycemia, they have not been rigorously studied but are likely to also apply at these gestational ages as well as the late preterm gestation. Benefit seems unlikely if the birth is more than 7 days after starting the treatment, but this has not been studied in the women at this gestation. While no long-term harms have been proved, one and large-scale observational studies necessary for the pharmacovigilance are lacking. So, what is the rescue course if the treatment more than 7 days ago? It likely to reduce the need for the respiratory support, and it likely to reduce the birth weight, head circumference and length, and neonatal blood pressure, and those effects are seen after the for the harms. And what are the recommendations? The clinicians and the women, they should consider the balance of the risk and the benefits of the corticosteroids in the women in whom the imminent preterm birth is anticipated from the 35 to 36 plus 6 weeks gestation. And these are the evidences: the evidence level 4, 2 plus, 4, 1 double plus, and 1 plus. So, is what particular circumstances they should antenatal corticosteroids be discussed with and offered to the women? Yes, the multiple pregnancy recommendations. The women with the twin and triplets, they should be offered targeted antenatal corticosteroids for early birth in line with the recommendations for the singletons. And the uncertainties around the benefits and the risk of antenatal corticosteroids in twins and triplets, they should be discussed with the women. And the single and multiple untargeted routine course of the corticosteroids, they should not be used in the twin or triplet pregnancy. Women, they should be informed that there is no evidence of the benefit in using the untargeted administration of the corticosteroids. So, what about the women with the diabetes? The diabetes, they should not be considered, and the absolute contraindication to antenatal corticosteroids to the fetal lung maturation in women with the diabetes who are receiving the corticosteroids. Additional insulin, they should be given according to an agreed protocol, and the close monitoring, they should be undertaken. For the women with the diabetes undergoing the planned cesarean birth between the 37 plus 0 and the 38 plus 6 weeks, an informed discussion they should take place with the women and her family members or the carer as appropriate about the potential risk and benefits of a course of the corticosteroids. Corticosteroid administration is associated with the increased rate of the neonatal hyperglycemia. So women with the diabetes, they have been excluded from most randomized controlled trials of the antenatal corticosteroids because of the concerns about their potential effect on the glycemic control. Maternal blood glucose levels, they rise shortly after the administration of the corticosteroids and can remain elevated up to 5 days. And one a systemic review and the meta-analysis identified no eligible studies in preterm birth outcome following the corticosteroid therapy in the pregnancy complicated by the diabetes. Pregnancy is complicated by the fetal growth restriction, preeclampsia, or the antepartum hemorrhage. The birth, they should not be delayed for the antenatal corticosteroids if the indication of the birth is impacting the health of the woman or her baby. NICE guidelines 25 recommend a course of the antenatal corticosteroids. They should be offered if a planned early birth is necessary for the hypertension in pregnancy. If imminent preterm birth is likely, a course of the antenatal corticosteroids, they should be offered to women whose babies are thought to be either the small for gestation age or to have the fetal growth restriction. But women, they should be counseled about the lack of the evidence to the guide the care. Preterm pre-labor rupture of membranes (PPROM) and antenatal corticosteroids, they should not be offered to women with the PPROM who are at the increased risk of preterm delivery, and this is currently limited evidence to recommend repeat course of the antenatal corticosteroids if a woman remains at imminent risk of the preterm birth 7 days after the administration of the antenatal corticosteroids. However, a further course may reduce the need for the neonatal respiratory support. The role of the antenatal corticosteroids in women presenting with the suspected PPROM from the 24 weeks gestation is addressed in RCG Green Top Guideline number 3073 and NICE 25. The WHO organization recommends that the corticosteroids are appropriate for the women with the PPROM who have no clinical signs of the infection. So, the administration of the repeat course of the corticosteroids is addressed in section 10. In women with the PPROM, the concerns have been raised that the multiple course of the corticosteroids may increase the risk of the chorioamnitis and the neonatal sepsis. So, what is the optimum dose and route of administration for the course of antenatal corticosteroids? And in the UK, it is recommended that 24 milligram dextromethasone phosphate is given intramuscularly in two divided doses, 12 mg, 24 hours apart, or the four divided doses, 6 hours apart. An alternative is the 24 milligram betamethasone sodium phosphate acetate mix given intramuscularly in two divided doses of 12 milligram 24 hours apart. Clinicians, they should be aware that the betamethasone phosphate, the preparation widely available in the UK, has different pharmacokinetics from the betamethasone sodium phosphate acetate mix, and there is little evidence to guide the effective dosage regime of this formulation. Oral or transplacental administration is not recommended. Antenatal corticosteroids are designed to cross the placenta, and they are given at the high dose that have been unchanged since the Lane's and the Hovey's original experiment in 1917. And what about the betamethasone? Betamethasone is available in two formulations. Betamethasone sodium phosphate is soluble with a short half-life, with the betamethasone sodium acetate is insoluble and has a long half-life. Dexamethasone phosphate, it is a soluble preparation and which is slightly cheaper than the betamethasone sodium and phosphate acetate mix, and the dose does not require refrigeration. Dexamethasone is included in the World Health Organization essential medicine list, and WHO managing the complications in the pregnancy and childbirth, a guide for the midwives and doctors, and is more commonly used in the low and the middle income countries. So, how long after the administration is a course of antenatal corticosteroids most effective? The antenatal corticosteroids used reduces the neonatal death when the first dose is given within 48 hours prior to the birth, and benefits are also seen when the first dose is given within 24 hours of the birth. And antenatal corticosteroids, they should still be given if the birth is expected within this time. Antenatal corticosteroids are most effective in reducing the RDS in pregnancies that birth between 24 hours and 7 days of the administration of the second dose of the antenatal corticosteroids. There was a significant reduction in the fetal and the neonatal death for the birth within 24 hours of the administration and within 48 hours. However, caution, they should be exercised in the interpretation of the data due to the limitations and the potential bias of the subgroup analysis in the original 2006 review. So, what are the risks associated with the administrations of the antenatal corticosteroids? The women, they should be counseled regarding the risk and uncertainties surrounding the evidence of the antenatal corticosteroids treatment, and institutions, they should use the standard guidelines for the assessment and the management of the neonatal hyperglycemia in the late preterm or the early term neonates who have received the recent antenatal corticosteroids. What are the risks to the women? Corticosteroids for the fetal lung maturity, there was no evidence that the antenatal corticosteroids increase the risk of the maternal infection, and they are known to increase the maternal blood glucose levels, and they have more likely to have an abnormal glucose tolerance test performed from the 72 hours after the steroid administration compared to the controls. And what are the risks to the baby? The babies who receive the antenatal corticosteroids, they affect the fetal growth, and they have a low birth weight that those that receive the placebo. And a dose response is seen. And the babies that receive the multiple course of the antenatal corticosteroids are more affected with the reductions in the weight, her circumference, and the length. So let's move forward. What are the contraindications to use the antenatal corticosteroids? The birth, they should not be delayed to administer the antenatal corticosteroids when there are the serious concerns about the maternal or the fetal conditions that will be alleviated by the expedited birth, and in the presence of the systemic infections, the potential beneficial effect of the antenatal corticosteroids instead of the baby, they are the balance against the effect of the exacerbating the severity of the systemic infection both for the woman and her baby. So corticosteroids, they suppress the immune system, so there is a risk that their use may activate the latent infections or the exacerbate the fungal infection in women With the systemic infection, it is may theoretically suppress the immune response to the infection, and there is no evidence to suggest that a single course of the corticosteroids increases the infections or antibiotic use, but the cautious they should be exercised when there is a systemic infection. In what circumstances they should an antenatal course of the corticosteroids be repeated? Women, they should be informed that there is no reductions in the serious morbidity or the long-term benefits they have been seen with the repeated corticosteroids, but the babies who receive the repeated doses of the antenatal corticosteroids are smaller, having the low birth weight and reduced length. And there is currently limited evidence to recommend the repeat course of the antenatal course if a woman remains at imminent risk of the preterm birth 7 days after the administration of the antenatal corticosteroids. However, a further course they may be reduce the need for the neonatal respiratory support, and the maximum number of the corticosteroids courses they given in and any one pregnancy they should not be exceeded 3. So here we conclude our session, this guideline, and which is the antenatal corticosteroids to neonatal morbidity and mortality. Stay tuned, and I'll see you next video. Take care.